All right, folks, 12:03. I think we can get started. Today, we're going to talk about COPD in 2025. And rather than going through the entirety of COPD from outpatient and inpatient medicine, I've decided to focus on what is relevant and germane for our colleagues working in the hospital, for hospital-based clinicians. So this is a focused presentation for those on the front line managing patients with COPD as they come into hospital and essentially catching falling knives. I'm Sacha Bhinder, adult respirologist from the Centenary site. You've probably seen me grand rounds many times in the past. This is always a very happy time for me to present to colleagues and to talk about probably the biggest aspect of my practice, which is COPD. Disclosures, suffice to say, I do speak on behalf of essentially every pharmaceutical company in the country with an extensive speaking, advisory, and consulting practice. I do also create content for local, national, and international CME organizations for accredited and non-accredited content. And I'm one of the editors of an upcoming journal, which will launch in March of this year, the Canadian Respirology Today Journal. I have extensive objectives. So we'll talk a little bit about history with respect to tobacco use and the impact it has on lungs. I want to dispel a very common myth of what happens when you quit smoking. We'll touch a little bit on COPD screening, which has relevance to inpatient and outpatient practice, and then we'll move into COPD. We'll talk about the impact of COPD, the impact of exacerbations and mortality, simplification of pharmacotherapy based on our current 2023 guidelines for management, the mortality benefit of single inhaler triple therapy, and very proud to say we have a new single inhaler triple therapy on formulary at the SHN, Breztri, which is a meter dose inhaler format, single inhaler triple therapy. We'll talk about device selection, carbon footprint. We'll talk about prompt initiation of triple therapy, move into exacerbations, patient perspectives on disease, and biologics. So little tidbits. This is being recorded as well. So if you do have to go, it is our busy season as respirologists, and it is your busy season as well. So please don't, if you need to go, it's being recorded as well. There are 63 inhalers that you can prescribe in Ontario. There are 25 in COPD, but at the end of this presentation, for hospital-based clinicians, there are three inhalers you need to be aware of. One is Ventolin, the meter dose inhaler, short-acting beta agonist that is ubiquitous in respiratory medicine. Every patient gets Ventolin. But there are two single inhaler triple therapies that you need to be aware of, Trelegy 100 and Breztri. Both are available at the SHN. Both are on formulary. And at the end of the day, the patient presenting with an exacerbation of COPD to one of our hospitals needs to be on one of these single inhaler triple therapies. That is it. If you remember nothing else from this presentation, COPD and a hospital visit is Trelegy 100 or Breztri single inhaler triple therapy plus Ventolin. And we'll talk about how this came to be. So a bit of history, and this is always nice to go back. This is from Fletcher and Peto from 1977, so almost 50 years ago. And it's a very elegant description of what happens with smoke exposure to the lungs. So y-axis is FEV1, forced expiratory volume in the first second, how much air you can blast out in the first second, which correlates to the elastic properties of the lung and the patency of the airways. X-axis is advancing age as you move from left to right. If you've never smoked or genetically your lungs are not susceptible to smoke, so you have a polymorphism of your matrix metalloproteinases and smoke doesn't cause laxity and loss of elasticity of lung tissue, your lungs will age like every organ and they will lose their elastic properties slowly with the passage of time. First myth to dispel. When you quit smoking, your lungs heal. They do not. If I was a gastroenterologist or specifically a hepatologist, perhaps I could make a comment that my organ does heal, but this organ, unfortunately, the lungs, it does not. The damage that is done is done. So if we follow someone that was smoking and decides to quit, all that happens is that the rate of subsequent decline starts to mirror that of the non-smoking population. But the damage that was done, the loss of lung function, that's lost. You just attenuate the ongoing rate of decline. And this is very important for patients to understand because they might quit after smoking for 20, 30, 40 years and have the false belief that the lungs will heal. They do not. And the impact of smoke is not necessarily readily quantifiable or accessible unless you do objective lung function testing. I can take 10 people of the same age, the same tobacco history, they'll have 10 different PFT results. You have to test. You have to screen. This is not necessarily something that you're going to do in the acute care setting, but when you see current or former smokers in the acute care setting, in the outpatient clinic setting, and in your offices, and they're presenting with exertional dyspnea, exertional intolerance, cough, sputum, one of many non-specific respiratory symptoms. Remember that symptoms of cough, sputum, dyspnea with chores, wheeze with exertion, colds that persist longer than people they know, those are pathologic symptoms. If you have a current or former smoker and the minimum threshold is 10 pack years, they're over the age of 40, and they say yes to even one of these symptoms that is pathologic: cough, dyspnea, exertional intolerance, wheeze, sputum, colds that persist longer than people they know, please order lung function testing. If it's not within your scope to order a pulmonary function test, please refer to your friendly neighborhood respirologist, and I'm more than happy to do so, as are my colleagues, of taking this individual, assessing the risk of COPD, and ordering lung function testing. Your inquisition with respect to these questions will be well rewarded, because we have a validation of the Canadian lung health test in a Canadian cohort, graphs above, but text below. If you ask a current or former smoker if they have one or more of those pathologic symptoms and they say yes, and you order a PFT, 1 in 4 patients will have a new diagnosis of COPD, and 93% of those patients will have mild or moderate early disease. The heartbreaking aspect of practicing respiratory medicine, of which there are many, is that I end up catching patients with COPD late in the disease course after multiple exacerbations, multiple hospitalizations. Screening is the only way we can capture current or former smokers with early flow-limiting disease by inquiring of those symptoms, asking them, ordering the test, and 1 in 4 chance we get a new diagnosis of COPD. This has to be part of our daily work. This has to be what we do with respect to screening current or former smokers. Sometimes you might feel it's overwhelming because there are a whole lot of current and former smokers out there, probably about 25% of the adult population. And this can be overwhelming, but it is very rewarding to capture this early in the disease course. So why do we talk about it early in the disease course? Because late in the disease course is where all of the bad outcomes happen. 400 million people globally having COPD, and that's hard to conceptualize when you're looking at the population of planet Earth. But worldwide, bottom left, third leading cause of death after ischemic heart disease and stroke. On the right-hand side, patients with COPD will die of respiratory, but also non-respiratory causes. And we're learning more and more of the impact of cardiovascular mortality for our patients with COPD. And it is the second most common cause of emergency department admission in most countries. And in fact, in Canada, it is the second leading cause of hospitalization. Up top, we see that it's the second most common reason for hospitalization, and the average length of stay is 7 days. Spending the night in the emergency department is not something most patients want to do. Spending a week in hospital is something that they would really love to avoid. And it is the second leading cause of admission to hospital for adults in this country after childbirth, after propagation of our species. The mortality within 30 days of hospital discharge is about 9%. It gets worse. If you have 1 or 2 acute hospitalized exacerbations per year, your 5-year mortality is about 50%. 3 or more hospitalized exacerbations per year, we're looking at 70% 5-year mortality. Even 1 moderate exacerbation treated in our office will increase the risk of future hospitalization by about 20%. And 2 moderate, risk of death goes up by 80%. You cannot escape death if you have COPD, and hospitalization, unfortunately, will move that closer to becoming a reality. Data on the left here is global. 1 in 5 patients with COPD will die within 1 year of their first hospitalization. Half of them will die from respiratory cause, but a quarter from cardiac. You admit a patient to hospital with an acute exacerbation of COPD, first time they've ever been in hospital. Respirology is consulted. We take that patient into our private office. There's a 1 in 5 chance that by that time next year, that patient ceases to exist in our EMR, that patient ceases to exist entirely. This is shockingly high. The data for Ontario is worse. This is mortality after first severe hospitalized exacerbation for those over the age of 65, and it is 27%. Now, of course, it's worse if you're over 85 and worse if you're 75 to 84. But overall, if you're 65 and older and it's your first admission with acute exacerbation of COPD in Ontario, 1 in 4 chance, 27%, of being dead within 365 days. We're having an event such as this to change this, because what we used to do in respiratory medicine was start something, wait for something to happen, and then add more. That doesn't cut it in the modern era. On the left side, y-axis is accelerated lung function decline. So the closer you are to the x-axis, the lower the lung function. X-axis is the march of time. The stars are exacerbations. The gray stars are unreported exacerbations. And you make a diagnosis of COPD in the top left. You start them on Ventolin. They have multiple exacerbations. You start them on a LAMA. They have more exacerbations. And by the time you get to triple therapy, on the bottom right, multiple exacerbations and loss of lung function have occurred, and mortality risk has been ever present. The right side is also shocking because this is the call to action. Many patients remain untreated for COPD. To say it's just COPD is to say that this is just a death sentence, unfortunately, because that's what, unfortunately, the mortality data indicates for our patients, that 35% of them have COPD and no maintenance treatment prior to hospitalization. Even after their first hospitalization, a third of patients had no prescribed maintenance treatment for management of their COPD. We have to prevent exacerbations by having them on the right therapy to do so, and we have to decrease the likelihood of them coming back to hospital by ensuring that they start that treatment in hospital, they're discharged from hospital with it, and they have a friendly neighborhood respirologist to manage them as an outpatient. So let's talk about triple therapy, because this is where it shines in preventing exacerbations, and it is exquisitely placed in our guidelines for patients presenting to hospital. First of all, our guidelines prefer single inhaler triple therapy over multiple inhaler triple therapy. If you've ever seen the bag of inhalers that patients leave hospital with and the multitude of inhalers that they have, no fault of their own, patients do not know which inhaler contains which medication. And unfortunately, I do a lot of primary care CME, and I will say that even for our colleagues in the community out at the front line, it is challenging to know which inhaler contains which medication. Simplification in life is very effective because it's less likely to lead to failure. Multiple inhalers, which one should I use, how often, different techniques, different dosing regimens, prone to failure. Single inhaler triple therapy decreases that risk. Demonstrated reduction of moderate and severe exacerbations of COPD, increased adherence, and a reduced chance of error in inhaler technique. This is an excerpt from our Canadian guidelines, and I'll pause by saying, if you're seeing a patient with COPD that you've encountered not through screening, because of course, if you screen, you'll catch mild disease. But if you see a patient in front of you with a history of COPD, or you catch them because they have an exacerbation, there's a 70 to 80% chance that the impairment of lung function is moderate or worse. These aren't mild patients. There's an over 60% chance that they're symptomatic to the point that if they're walking on their own, at their own pace, they have to stop because of dyspnea or slow down to avoid stopping, or they can't keep up with an 8-match PA. They are symptomatic. In our Canadian algorithm for pharmacotherapy, they're on the right side, symptomatic COPD. It occupies 2/3 of the algorithm for a reason. But the third criteria for assessment of pharmacotherapy for COPD is exacerbation risk. And here it is clear. If you have 2 outpatient exacerbations, so something you treat in the office, or the primary care practitioner is treated in their office, or they have 1 severe exacerbations, they walk into the emergency department, they're admitted to hospital, or they're in the ICU. All 3 of those scenarios are severe exacerbations. Bottom line, if you have COPD, it exacerbates, and you received care in the hospital, the The only treatment for that patient is single inhaler triple therapy, LAMA, LABA, ICS. We're simple people respirologists. We have three drug categories. Single inhaler triple therapy combines all three into one. Your friendly neighborhood respirologist on the consult service is going to add other things. And you've seen us do this with chronic azithromycin, roflumilast, Daxis, a PDE4 inhibitor, mucolytic therapy with N-acetylcysteine, and as we'll touch on at the end of the presentation, biologics are coming for COPD. These are other things that we can add on as we manage that patient in our office and co-manage with primary care. But from the moment they're admitted to hospital, single inhaler triple therapy, please. I'm going to reiterate this point multiple times in the presentation, but unlike pills, inhalers are sunk cost. If you prescribe Crestor and the dose is changed by the cardiology service, the little pills of Crestor that were in the patient's drawer go back to pharmacy and can be reused. But once an inhaler is dispensed at the patient's bedside, it's not reused with another patient. So if the patient is admitted to hospital with anything other than single inhaler triple therapy, respirology will change that to single inhaler triple therapy. The inhalers that were dispensed, let's say they're home inhaler regimen, that might be used in hospital for 1 or 2 puffs only, and then it's discontinued. The cost of that is sunk. Generally, inhalers are about $100 each. So if you think about every time you admit a patient with an acute exacerbation of COPD, and pharmacotherapy is prescribed that isn't Trelegy 100 or Breztri, that is money that is lost. We're not a hospital system that has money to burn, and this, unfortunately, is a very good way to stop the burn associated with pharmacotherapy and COPD. Triple therapy from the beginning, from the point of admission. It's not in their best past medication history because maybe they were on Brio 100 or Spiriva or Zenhale and Spiriva and some combination of inhalers that you can think of. But from the point of admission, single inhaler triple therapy. BPMH will be what they were on before, but what they will be on from now on is single inhaler triple therapy. Why? Well, prompt initiation, first of all, is better than delayed initiation. And there was a very elegant study in the United States that looked at prompt initiation of single inhaler triple therapy in 30-day increments. Bottom line, on the left-hand side, in a European cohort, if you had prompt initiation of single inhaler triple therapy within 30 days of that hospital visit, you had a significant reduction of recurrent exacerbation and therefore significant reduction of readmission to hospital. And on the right-hand side, you can quantify that for essentially every 30-day delay in initiating triple therapy, you have a 10% increased risk of recurrent exacerbation. And if you have prompt initiation within 30 days, all of these bad outcomes for patients, moderate or severe exacerbations, hospitalization, readmission, or even all-cause ER visits and all-cause hospitalization, all of those adverse outcomes for patients and a healthcare system and a hospital system improve. So I alluded to the fact that we have Trelegy 100 and Breztri on formulary. Now, Trelegy 100 has been on formulary for quite some time. Breztri is new. This is a new addition in 2024. It is a single inhaler triple therapy in a format that patients and providers are very familiar with, a metered dose inhaler. So some of our patients do prefer metered dose inhaler pharmacotherapy, and providers, specifically, let's talk about long-term care homes, older adults where technique is often a challenge and medication is administered by someone else. Metered dose inhaler with an aero chamber is a very effective way of delivering medication to a patient by a provider. 3 drugs, ICS, LAMA, and LABA. Inhaled corticosteroid is budesonide. The long-acting muscarinic antagonist is glycopyrronium. The long-acting beta agonist is formoterol. It's 2 puffs twice a day. And the data demonstrates in the landmark Ethos clinical trial, where about 60% of patients had 2 or more exacerbations in the previous year, that single inhaler triple therapy with Breztri in the middle was far more effective at preventing exacerbations of COPD, moderate or severe, compared to dual bronchodilator therapy on the left. 24% reduction, number needed to treat was 3. And even if you take a patient on ICS LABA, in this case on the right-hand side, it was Symbicort. Well, Symbicort has an ICS, it has a LABA, but it's missing a LAMA. And when you add a LAMA to Symbicort and you get Breztri, single inhaler triple therapy, you have a further 13% reduction of exacerbations. All roads lead to triple therapy for very good reason, because being on single inhaler triple therapy means the road that you're on is less likely to have exacerbations and hospitalization. Multiple inhaler triple therapy is no more. Now, when I say no more, of course, there are exceptions to this because the art of practicing clinical respiratory medicine is that sometimes you have a good attempt at Trelegy, you have a good attempt at Breztri, and the patient can't tolerate it, and we have to open to multiple inhaler triple therapy. It is only after a patient has failed single inhaler triple therapy that I would do that. Single inhaler triple therapy is the recommendation up front, and there's further data to support it. Here, the y-axis indicates cumulative exacerbations. X-axis is the passage of time over 1 year. You have about a 32% reduction of exacerbation on one inhaler with all three compounds versus 2 or 3 inhalers with all 3 compounds. And of course, we need to compare this to other compounds. Now, COVID-19 vaccines are on the right-hand side. Let's ignore COVID-19 vaccines for a bit here. Let's just focus on the middle and let's focus on the left. If we want to talk about the number needed to treat to prevent an exacerbation of COPD, moderate or severe, Ethos clinical trial of Breztri, Impact clinical trial of Trelegy 100 was 3 and 4 respectively. But by the time I make it to my morning snack in clinic on a Monday, by initiating triple therapy in the office, I've prevented a moderate or severe exacerbation that day. Now, if we want to compare this to number needed to treat for landmark cardiovascular studies for effectiveness, so HOPE, ACE inhibitor, versus EMPA-REG outcome study looking at SGLT2 inhibitor versus placebo. Now, granted, these were placebo-controlled as opposed to dual bronchodilator for the COPD studies, but it's a couple of orders of magnitude difference between the number needed to treat on the left-hand side versus number needed to treat on the right-hand side. This is a high-yield intervention of preventing exacerbations of COPD when you switch to single inhaler triple therapy. And I alluded to this earlier with respect to cardiopulmonary outcomes. We know that about a quarter of deaths associated with COPD are caused from a cardiac etiology, and about 50% from a respiratory etiology. Here we have data demonstrating for one of the first times that single inhaler triple therapy has a significant reduction of the first severe cardiopulmonary event, which is a major adverse cardiac event, COPD exacerbation, or death due to a respiratory cause. So it's a combination endpoint. There is strength here of recognizing that if you prevent adverse systemic and pulmonary inflammation from occurring in the setting of an exacerbation of COPD, you can prevent that same inflammation from destabilizing a cardiovascular status. We know that inflammation and acute plaque rupture, unstable plaque, this is a common phenomenon that we see and a common mechanism leading to adverse cardiac outcomes. An exacerbation of COPD is a profound inflammatory response that leads to that systemic inflammation that can cause these adverse cardiac outcomes to occur. Prevent the exacerbation, prevent the adverse cardiac outcome. So if we want to go back to 2018 and look at the Impact clinical trial of Trelegy 100 versus Anoro or versus Brio 100, of course, I wish on the right-hand side that I could get exacerbations down to 0. Unfortunately, I can't. But Trelegy 100 single inhaler triple therapy is far more effective than Brio 100, far more effective than Anoro. If you admit this patient with an acute exacerbation of COPD, or you treat it in your office, or you treat it in the ED, if pharmacotherapy for that patient is anything less than Trelegy 100 or Breztri single inhaler triple therapy, it is a disservice to that patient because that patient is doomed to repeat that exacerbation with a higher likelihood than if they were on single inhaler triple therapy. This was the takeaway from the Impact clinical trial in 2018. And the Breztri clinical trial called Ethos that followed in 2020 has similar outcomes of reduction of exacerbations compared to dual bronchodilator as well as ICS-LABA. So let's talk about all-cause mortality because I've been pointing fingers at mortality in COPD, and very fortunate for us, now we have 2 inhaled therapeutics that can actually do something about it. When we look at all-cause mortality in the Ethos and Impact trials, On the left and right-hand side, we see a mortality benefit for single inhaler triple therapy compared to dual bronchodilator or ICS-LABA for Breztri and Trelegy. This is Trelegy 100 on the right, Breztri on the left-hand side. You don't need to worry about any numbers beside Breztri. Breztri is like Prince. It just has one name. It's Breztri. At the end of the day, the number needed to treat, 80 and 120, this is not unreasonable. I mean, I have a big COPD practice, and probably by the time I get through to Wednesday afternoon or Thursday in my office, I've seen enough patients that I've been able to prevent one death over the course of that next year. You do that 52 weeks out of the year, that's 52 deaths prevented. The number needed to treat is there. This is the power that we have with inhaled therapeutics. We have not seen inhaled therapeutics before IMPACT and ETHOS showing a mortality benefit in phase 3 randomized controlled trials. This is very powerful evidence. That's why both of these single inhaler triple therapies are on formulary. Because for the first time, we can reduce the risk of mortality in the setting of COPD by prescribing single inhaler triple therapy at that time of that severe hospital exacerbation or when we manage these exacerbations in the office. Now, you're going to look at the numbers on the left-hand side of mortality reduction. This is absolute risk reduction of mortality. For Trelegy 100, it was 0.83%. For Ethos, it was 1%. You're going to look at that and say, oh, Dr. Bhinder, those are really small numbers. I mean, come on, like 0.83, the first number beside it is a 0. These are small numbers. But what about Scandinavian Simvastatin Survival Study, 4S, HPS, HOPE, UKPDS? Landmark cardiovascular studies that were practice-changing at the time of press release, let alone publication. The annual all-cause mortality reduction for these landmark cardiovascular studies is actually numerically a bit smaller than our respiratory studies, but taken together, on par with landmark cardiovascular studies. Our patients with cardiovascular disease, with diabetes, deserve statin ACE inhibitor, metformin initiation. Our patients with exacerbating COPD deserve single inhaler triple therapy with Trelegy 100 or Breztri. When we want to look at all-cause mortality of single inhaler triple therapy versus multiple inhaler triple therapy, I'm presenting this for a reason because it's positive. We see that there is a significant reduction, but 19%, of single inhaler triple therapy versus multiple inhaler triple therapy. One inhaler with all three compounds, less likely to result in the patient dying compared to multiple inhalers with all three compounds. It's for this reason that our Canadian guidelines place this front and center. The patients that you see in hospital are symptomatic. The patients that you see in hospital are unlikely to have mild COPD. And if you're seeing them in the ED or worse, or they've come multiple times with outpatient exacerbations, and you're seeing them in the general medicine clinic or in your private office, these are individuals that are at high risk of another exacerbation of COPD and mortality. The best indicator of future behavior is past behavior unless you change that behavior. And single inhaler triple therapy is that intervention leading to change. We also have an option, and I'll just go back a slide here. We also have an option for patients with infrequent exacerbations, but higher symptom burden that are on dual bronchodilator therapy to escalate to single inhaler triple therapy. Now this patient population and this phenotype is not necessarily the focus of today's presentation, but we know that when patients are on COPD medications and they continue to have symptoms, or the symptoms that they have were better treated before and now they're actually coming back, or God forbid they have an exacerbation on treatment, the escalation is to single inhaler triple therapy. All roads lead to it for a reason. But sometimes phenotype changes. And the question is, what do you do when you're at single inhaler triple therapy for these patients? Do we ever de-escalate? Well, 5 years ago, I would have said to you that de-escalation is a consideration. Now we have new data demonstrating that de-escalation is the wrong thing to do. We have an elegant clinical trial called Kronos, which demonstrated that if you take patients with single inhaler triple therapy management in the setting of COPD, and they do not have a history of previous exacerbation, so their phenotype has changed, but they're on triple therapy. If you de-escalate them to dual bronchodilator therapy or anything less than triple therapy, they have worse outcomes. They have an increased likelihood of exacerbations. We don't de-escalate anymore. You're on Trelegy 100 or Breztri, and that's what you're on for life. We only add to it. That's the takeaway from Chronos, and that's also the takeaway from clinical practice. Don't feel vexed about what to do when they're on triple therapy. There was nothing more to do with the inhaler. Your friendly neighborhood respirologist can add more to it, but they stay on one of those two dual bronchodilators. So let's talk about a hot topic. Granted, I think after next Monday, at least in the Western Hemisphere, this may be less of a hot topic, but granted, being less of a hot topic will probably contribute to more global warming, and it'll be another hot topic, but that's a different Grand Rounds presentation. Climate change and choice of inhalers for patients with respiratory disease. I'm going to start with an assessment here. If we're looking on the x-axis of a moderate or severe exacerbation and the weeks leading up to it, the data demonstrates that these exacerbations don't happen overnight. This is an inflammatory bomb that starts to smolder and then goes off. It's not just a sudden detonation 48 hours before admission. If you track lung function of these patients, and randomized control trials are the best way to get this data, you see that lung function begins to deteriorate 3 to 4 weeks before they hit that point where they present to the emergency department. And it never recovers fully after the exacerbation, even 2 weeks out. We see this in clinical practice. The point I'm making about this, and this is an excerpt from our position statement on climate change, is that during emergencies, some patients with COPD and asthma may not be able to effectively inhale from a dry powder inhaler. And they try to get the dry powder inhaler into the chest, and they just can't get it in. They prefer meter dose inhalers in that context. And some patients may just prefer meter dose inhaler pharmacotherapy to begin with. The key aspect here is that when we're looking at carbon footprint and greenhouse gases for meter dose inhalers, it is not a question of we should not prescribe meter dose inhalers. That's not what our guidelines ask us to do. That's not what our position statement asks us to do. Our position statement asks us to have a shared decision-making approach to ensure that the patient is on optimal pharmacotherapy for management of COPD, recognizing some may prefer meter dose inhalers and some may not be able to inhale from a dry powder inhaler when they have an exacerbation. I see this in my office. Patients will have pharmacotherapy with a dry powder inhaler. They will start to have an exacerbation. They feel that the inhaler, quote unquote, stops working. They use a lot of Ventolin. Their exacerbation is treated with antibiotics and prednisone. They recover back to a new baseline. They've lost a bit of confidence in that dry powder inhaler because when they were at their worst, when they were in an exacerbation, they felt it failed them. They start to overuse Ventolin. So this was studied in a study called Exactose Carbon. And this is a very busy slide. I keep this for your reference, but I just want to comment on two things. Bottom left, if you look at the metric tons of carbon dioxide caused by COPD, 75% of it is due to inpatient hospital care. Preventing exacerbations, preventing hospitalization will prevent carbon dioxide output that accounts for 75% of what we use in COPD. Primary care, outpatient care is less than a quarter. 75% of carbon footprint in COPD is hospitalized inpatient care. And on the right-hand side, about 60% of carbon output from COPD medications is Ventolin, short-acting inhalers. I want our patients to be on optimal effective single inhaler triple therapy to prevent those inpatient exacerbations, a format that gives them confidence that I can get the drug into my chest even when I'm at the peak of my exacerbation, and minimize the need for Ventolin. I'm not saying we don't prescribe Ventolin, I'm not saying we stop Ventolin, but we have to ensure that they're on optimal therapy to minimize the medical need for Ventolin. It is always there as a reliever 24/7. But if we minimize the need for Ventolin with optimal pharmacotherapy, we decrease that carbon footprint, we decrease hospitalizations and inpatient care. That makes a difference on the carbon footprint of COPD as an entire disease, not just myopically looking at inhaler devices themselves. Promptness matters, and I mentioned this earlier before. This is just more data along the same theme that if you look at all-cause readmission to hospital or COPD-related readmission to hospital, starting inhaler therapy with single inhaler triple therapy within 30 days, better than within 60 or 90 days. And if we go even further, looking at within 30 days or within 14 days, the sooner the better. The call to action here is single inhaler triple therapy from the point of the admission order set. Trelegy 100 or Breztri, you pick. You know the patient in front of you. You can assess what will probably be effective for them, which inhalers they've been on in the past, what works, what doesn't work. Trelegy 100 or Breztri, both are on formulary. Respirology sees that patient. If the patient has a respirologist, of course, as an outpatient, they'll go back to see their friendly neighborhood respirologist. But if they don't, the friendly neighborhood respirologist consultant should become the outpatient respirologist following this patient until one of them leaves this world. And that after visit summary patient instruction section should be populated with their information, and they should take care of all of that outpatient journey because promptness matters. That discharge summary leaving hospital should mention Ventolin and one of the two single inhaler triple therapies. And that completely removes the obligation of responsibility for our primary care colleagues in the community. They'll get a discharge summary showing that something awful happened to their patient. They were admitted, they saw specialists, they were well managed, they have a comprehensive discharge plan and outpatient management plan. The discharge summary to the family physician is mainly an FYI from a COPD perspective. If we do this, if what I described right now, which our guidelines recommend with respect to pharmacotherapy, is implemented, this pays dividends. This was the Prometheus study, which was presented at the European Respiratory Society meeting just late last year in Vienna. Beautiful city if you've never been. Very much recommended. If we implement single inhaler triple therapy as recommended by our guidelines, we will extend patient life with COPD in Canada by 1.7 years. We can avoid over the next 10 years 180,000 deaths from COPD. And the direct cost savings will be around $3.5 billion saved. The right-hand side demonstrates graphically what would happen. If we keep doing what we're doing, we won't have these benefits. Change has to happen. So let's talk about exacerbations as we close the presentation. Biggest reason for hospitalization outside of pregnancy. Exacerbations are characterized by one of three symptoms. Could be one, two, or three. They have increase in dyspnea, or increase in sputum volume, or increase in sputum purulence. There's a fourth one. Sometimes they feel that the mucus has changed and it's stickier. It's stuck in the chest. I feel it's in my chest. I'm congested. There's more of it. I can't cough it up. The viscosity has changed. Significant negative outcomes associated with COPD exacerbations that I've highlighted. And like most things, best indicator of future behavior is past behavior. Lots of factors that predict frequent exacerbations. Previous exacerbations, severity of disease, chronic bronchitis phenotype, reflux, and also blood eosinophil count, which is going to become important as we get into the biologic era. At the end of the day, when we're focused on exacerbations and how we should evaluate exacerbations, the severity of the exacerbation is determined by where the treatment occurs and what was the treatment. If the patient decides that, you know what, Saturday morning, I'm going to clean the bathroom. They grab a Clorox bleach spray. They don't open the window. They don't turn on the ceiling fan. They spray the shower with bleach. Of course, they're going to have an inhalational injury. That patient with COPD will have more cough, more mucus, more phlegm, more dyspnea for the next 48, 72 hours. They'll use more Ventolin. They may call my office, leave a voice message. I call them back Monday morning, and they say, yeah, the weekend was rough after I used all of this bleach, but better now. Mild exacerbation. They just had to take more Ventolin. If you need to prescribe prednisone plus minus antibiotic as an outpatient, that's moderate. But by definition, you walk in the doors of the Scarborough Health Network to have your exacerbation treated, and it's severe. Increase in sputum volume or purulence and worsening of dyspnea provide clues to treatment. Now, the best clinical predictor we have amongst many poor predictors that an exacerbation is bacterial is purulent sputum. Purulent sputum is not definitive for bacterial infection, but at the end of the day, it is the best clinical predictor we have of many poor predictors. We have lots of predictors. Severe disease, more likely to be bacterial. 4 more exacerbations in the previous year, for sure. Very high risk of being bacterial. Hospitalization in the past 3 years, but purulent sputum, look at the odds ratio. 27 versus numbers between 2 to 5, 2 to 6. Purulent sputum is not Definitive. It's not 100%. You can have purulent sputum on a chronic basis as part of your chronic bronchitis phenotype. But if it worsens, more of it, thicker, change in viscosity, accompanied with dyspnea, more likely that it's going to be a bacterial infection. So what do we do in the setting of acute exacerbations? And I kept this to one slide because when I look through charts at the SHN and see these patients on the consult service, this is excellent care. But there's a couple of tweaks here. Very reasonable to use Ventolin. In the setting of exacerbations of COPD and asthma, beta receptors are upregulated in number and density. So these patients become more Ventolin responsive, beta responsive, very reasonable to be aggressive with Ventolin. You can add Atrovent, but cholinergic receptor density tends to be stable in the setting of an exacerbation. So they don't have more cholinergic receptors. So why am I adding Atrovent here? I'm adding Atrovent because it's possible that their outpatient LAMA-containing pharmacotherapy, they weren't getting the full dose into the chest. Some of those receptors remain unbound with drug. So you're adding a short-acting muscarinic antagonist, Atrovent, because you're not confident they got the full dose of a LAMA-containing drug. But within 24 hours, 48 hours of that hospitalization, I stopped the Atrovent. If they're confidently using and reliably using their controller therapy, Trelegy or Breztri in hospital, I stop the Atrovent because the last thing I want are anticholinergic side effects. Ventolin, of course, continues. Prednisone works, does many good things: lung function, oxygenation, shortens recovery time, treatment failure, relapse, but it's not vasculitis. Our emergency department physicians are catching patients when they are deteriorating, and they may order high doses of IV steroids, but it doesn't get you any farther or further. You can slam them with high doses of intravenous steroid. All you're doing is adding to the indelible long-term consequences of intravenous and oral corticosteroid for patients with COPD and for asthma. The duration of therapy and the high dose versus low dose doesn't make a difference. Oral prednisone is preferred, please. Let's limit IV use. Duration of therapy should not normally be more than 5 days. Now, sometimes when we know our patients well and know their exacerbation pattern, some older patients do develop an element of relative adrenal insufficiency and they benefit from a taper, but not all patients need that taper. 5 days of 40 milligrams of prednisone in the REDUCE trial, published way back in 2012, was equivalent to 14 days of 40 milligrams of prednisone when it comes to repeat exacerbations and lung function at 6 months. More isn't better. Less is effective. 5 days, 40 milligrams orally. Antibiotics, short recovery time, reduce the risk of relapse, treatment failure, and of course, kill bacterial infections. Again, duration of therapy is about 5 days. Now, again, you can always extend the burden of sputum, more bacteria, more bullets, that logic applies. And actually, our bronchiectasis guidelines from the European Respiratory Society say that if the patient has an exacerbation of bronchiectasis, recommendation for antibiotic duration is 14 to 21 days, 2 to 3 weeks of antibiotics. More bacteria, more bullets, more nooks and crannies for those bacteria to hide in, need more time, need more bacterial exposure. Most common sputum culture and sensitivity result in the setting of COPD: normal respiratory flora. If you're treating in the office, azithromycin and doxycycline with prednisone for 5 days, very reasonable. If you're treating in hospital, more severe patients in the office, clavulin preferred over Avelox, again, 5 days and oral. If we want to look at what matters to patients, because we've talked a lot here about things we will do and offer patients for management of COPD with good intention, there is actually alignment. So privileged to be able to discuss this with you today because this was discussed again at the ERS meeting in Vienna in September of last year, looking at global patient preferences and disease perspectives with respect to disease stability for patients. Now, if we highlight the top 6 valuable things for patients: no moderate or severe exacerbations, no inpatient stays, no decline of lung function, able to do regular daily activity, lung function improves, I get a mortality benefit. This is very reasonable. And for those managing chronic disease, you can insert your chronic disease here. And I think your patients will probably be aligned with this. I don't want to be in hospital. I don't want to have a flare. I want my organ function to be stable. I want to do what I want to do and overall live longer to keep doing that. This is very sensible for patients. The challenge, though, is that if we look at the perception of COPD control by respiratory physicians and the current state, even considering triple therapy, we're not there yet. This was a cohort of 4,300 patients. And if we look at those 4,300 patients and then take those who are frequent exacerbators, two more moderate outpatient exacerbations or one severe exacerbation, and then further look at those on triple therapy, and then also exclude those who develop COPD from non-smoking, occupational biomass, the developmental abnormalities. There's many causes of COPD that do not involve tobacco use, but tobacco use is still the dominant at about 75-80%, depending on the cohort. And we look at those 400 patients that I would say are the ones that come to our emergency department, frequent exacerbation, on triple therapy, current or former smokers, and compare it to the broader cohort. I've highlighted two key questions. If we ask respiratory specialists that, how do you feel about the management of these patients with COPD, the broader cohort? Well, 42% say that they're satisfied and they believe that this is the best that can realistically be achieved for this patient. But if I look at this more severe cohort, recurrent exacerbations, triple therapy, current or former tobacco use, it's a bit disheartening. 40% of colleagues will say they're not satisfied, but they actually feel that this is the best possible control that can be achieved for this patient. They basically saying, no, this still sucks, but I can't make it suck any less because this is all I can do. And this is the current state that we're living in. But this is not the future. The future is biologics in COPD. Now, if you're familiar with biologics in asthma, prepare for an avalanche because probably within the next 5 years, we might have somewhere between 4 to 7 biologics for COPD, in addition to additional biologics for asthma. But biologics for COPD are effective when we have the right phenotype. So adult patient population, eosinophil count 0.3. I talked about this earlier, that 0.3 eosinophils or higher, and you'll see this mentioned in our consult notes when it's there. 0.3 eosinophils or higher is an exacerbation signal. Now, of course, they're current or former smoker. They have recurrent exacerbations, 2 moderate or 1 severe. They have a chronic bronchitis phenotype. They are short of breath, modified MRC class 2, such that walking around Scarborough Town Center at their own pace, they have to stop because of shortness of breath, or they have to slow down to avoid stopping, or they can't keep up with an age-matched peer, let's say a spouse. And their current treatment is single inhaler triple therapy. So this is a chronic bronchitis, frequently exacerbating eosinophilic dyspneic phenotype. And we start them on Dupixent. Well, taking the current state that our colleagues say 40% of the time, I'm not satisfied with this, but this is all I got. Well, we have a further 30 to 34% reduction of moderate or severe exacerbations by taking that patient on triple therapy and adding Dupixent injectable therapy twice a month onto that patient's regimen. That is a huge reduction. That is a reduction numerically that is greater than the reduction of exacerbations going from dual bronchodilator therapy to triple therapy, from ICS LABA to triple therapy. This is a huge reduction of the risk of exacerbation. And when we pool these trials together, this was presented at ERS back in September, we saw a 31% reduction of severe exacerbations causing hospitalization. This is the future, folks. The future is targeted pathway inhibition to obliterate this type 2 inflammatory phenotype in asthma, atopic dermatitis, chronic rhinosinusitis with nasal polyps, eosinophilic esophagitis, and now COPD. It is targeting the level of the epithelium, targeting the subepithelial pathways that drive exacerbations that lead to this explosion of inflammation, and preventing those exacerbations and preventing all of those downstream outcomes that negatively impact patients when they have one of those events. New kid on the block. Now, this is Nucala, which is a biologic called mepolizumab in COPD. All I have, unfortunately, is a investor relations press release because the final publication is still pending. We should have this data first quarter of 2025. But Nucala was studied in the Matinee clinical trial as a biologic for COPD, and bottom line, meets its primary outcome of preventing moderate or severe exacerbations of COPD. What is very interesting, and publication of this will be very interesting to see, is that because of the pandemic, they changed their clinical trial design. So some patients were followed for 2 years. The previous trial for Dupixent, Notus, and Boreas was 52 weeks. That's it, 1 year of follow-up. Now we might have data demonstrating, hey, what happens with a powerful biologic in COPD for 2 years as opposed to 1 year? Bottom line, screen for COPD, please. Refer current or former smokers with respiratory symptoms for PFT and consult. Your friendly neighborhood respirologist will take care of this. We can even see them in hospital, have the consultation in hospital, arrange testing and follow up as an outpatient, but it is meaningful for patients. And you know what? Patients really do value when they see clinicians and colleagues in hospitals. There is extra weight placed upon opinions rendered in hospital than in the community sometimes. So if we have an opportunity to see this current or former smoker with respiratory symptoms, it's well worth us coming, assessing the patient, arranging testing as an outpatient, straightforward consult, high value for the patient, and of course, 93% chance that will have mild or moderate disease on screening. Mortality from COPD exacerbations is shockingly high. Single inhaler triple therapy is the most effective inhaled treatment we have to reduce mortality from COPD, and it is guideline recommended from the get-go, from the point of admission. It should be a part of that admission order set. You order Trelegy 100 or Breztri, both in formulary. You ignore all of their home pharmacotherapy. Anything that they were on before coming to hospital is immaterial. You start them on one of those two from the point of hospitalization. Let's save some money for the hospital as well. No de-escalation from single inhaler triple therapy. Antibiotics and prednisone for 5 days. Biologics are coming as well. Now, if you like this presentation, I do have a couple more grand rounds coming up in the future. This is the last slide, folks. Wednesday, March 12th, I'll be presenting Medicine Noon rounds on asthma biologics. So I might have an update for COPD biologics at that time that I will squeeze in, but we'll have a comprehensive review of biologics in asthma and how you can optimize pharmacotherapy for your patient with asthma to allow us to initiate a biologic in the respiratory office. Also, we have new data on cardio-respiratory collaboration and a Delphi consensus of how cardiologists and respirologists can work closely together. I am actually one of 3 respirologists in Canada that has a practice inside a group of cardiologists. So there's only a few of us, literally 3 of us in the country, that have respiratory practices inside the office of cardiologists. So we have a new Delphi consensus on this collaboration that I'll present to cardiology grand rounds in June. And we'll have an upcoming white paper as well that is pending publication on encouraging cardiorespiratory collaboration. I'm happy to stay for the next couple of minutes and answer questions, but otherwise I will leave you to move on to your afternoon and have yourself a wonderful day, week ahead, and upcoming weekend.
I have one question.
Mm-hmm.
I came in late. Sorry, Sacha, but
It's okay. No worries.
I'm gonna show my ignorance here because I haven't really, as a GI, I don't usually deal with this a lot. But I want your what's the current state of beta blocker use in COPD? Because I haven't kept up to date on that, but obviously I use beta blocker.
Yep.
And I just want to know what the latest is, or has there been a definitive answer on that?
So the definitive answer is that beta blockers are safe in the setting of COPD. And if a patient has an indication for a beta blocker and they have COPD, the beta blocker should not be withheld.
No, so you would use this. You would use you would still use that LABA, like your SIT,
correct,
in someone with a beta blocker.
Okay. Correct. I would ensure that the patient is, of course, on maximal pharmacotherapy and COPD based on our guidelines. But if you say to me, this patient needs a beta blocker and they have COPD, can you use it? The answer is absolutely yes, you can. The one part here, though, is that what's been well studied are cardioselective beta blockers. So metoprolol and bisoprolol. More emphasis on bisoprolol. If you're going to use atenolol, carvedilol, propranolol, what I would recommend, because of the non-cardioselective, if there's an opportunity of up titrating and monitoring for effect, that is best. Patients do tolerate non-cardioselective beta blockers. Sometimes what we need to do as respirologists is potentially change their inhaler. So now we're getting a bit into the weeds here. Certain long-acting beta agonists bind more strongly to respiratory beta receptors than older generation beta agonists. So I found that if someone requires propranolol, or let's say atenolol or carvedilol, if I change their inhaler to something that's a bit more effective at binding to those beta receptors, if they did have a bit of increased respiratory symptoms with initiation, that goes away. So this is a quick fax to the respirologist, or even a request for a consult as an opinion. But if you're planning on starting a cardioselective beta blocker, no issues. If it is non-selective, something that slow up titration and monitoring for symptoms is fair. But we have therapeutics that could really overcome the effect of that beta blockade to a large extent and allow them to be able to co-manage both conditions without issues.
Great, thank you.
My pleasure. All right, folks, 12:59. I'm going to get going in the afternoon and sign off. Feel free to email any questions if you have, and I will look forward to seeing you in March and then in June. Have a great day, everyone.